Good morning, good afternoon, and good evening, everyone. Thank you for joining us today on this important webinar session. So, my name is Tersit. I'm a global primary healthcare program lead at the International Institute for Primary Healthcare in Ethiopia. So, today we'll be having a great session, hopefully, with the senior experts on the area from Ethiopia, Uganda, and from US Hopkins University. So this session is part of our monthly webinar session uh, series that is entitled with Strengthening Primary Healthcare System in Low and Middle Income Countries. So this has been happening for the last 4 years, and it continues to be a great platform to connect with overall over the world with experts on the area and to share learning experiences and practical experiences. So I hope you will have a great session today as well. So it's great to and honored to have these experts today lined up, and also our moderator, Professor Biniam. So I'll be introducing uh, briefly Professor Biniam to lead the session, and we'll start from that. So Professor Biniam Telahun is a full professor and founding director of the Center for Digital Health Implementation Science at the University of Gondar. With over 20 years of global experience in digital health across the continent, he has led numerous global level projects advancing the fields at intersection of digital health and primary health care. Over the past decade, he has worked closely with the Ethiopian Ministry of Health and six leading Ethiopian universities to establish and scale the capacity building and mentorship partnership program and bridging academic and health system. Is accomplished researcher with more than 2015 policy relevant publications conducted in close collaboration with health system implementers. He completed his postdoctoral fellowship in digital health implementation science at the University of British Columbia, Canada, and earned his PhD in medical informatics from University of Münster, Germany. He has received several prestigious awards and holds memberships in distinguished global scientific societies, including being a fellow of the International Academy of Health Science Informatics and the Ethiopian Academy of Science, both recognizing his global expertise and scientific excellence. So it's been a great pleasure to have you, Professor Priam, and also to have you on the panel and as an expert on the system. So I hope we will have a great session today. So I will hand it over to you. Thank you.
Thank you very much. Thank you very much, Tersit. Good morning, good afternoon, everyone. Today we are going to have a great session on a very interesting topic of artificial intelligence in primary healthcare. A question which everyone has been asking, everyone want to explore as artificial intelligence is growing. As we know, primary healthcare is also the foundation for every effective health system. And today, artificial intelligence offers a powerful opportunity to strengthen it, especially in low resource settings where resources are limited but the needs are high. AI can support frontline health workers with better decision making. It can enable early disease detection, and it can help us turn routine health data into actionable insight for communities as well as for policymakers. However, realizing the potential requires more than technology. It demands strong data system, it demands skilled workforce, and thoughtful governance to ensure equity, trust, and then ethical use of AI, especially in the sensitive area of healthcare. As we explore AI in primary healthcare, the key question is not whether AI is important or not. AI is already here right now, but how we can do so in a way that is practical, scalable, useful for our health system, and impactful for our community. with all those open questions. Today, we are joined by 3 distinguished speakers who has ample experience in using AI in different contexts and also who are leading different innovative AI initiatives in the health sector. First, we have Dr. Qingfeng Li from the Johns Hopkins Bloomberg School of Public Health. We have Dr. Ruthaisire Mehdi from the Ministry of Health in Uganda. And also we have Mr. Tamane Fayisa from the Last Mile Health in Ethiopia. Interestingly, 3 of the speakers from different sectors, including academics from the NGO who is leading implementation on the ground, as well as from the government, from the ministry, who all the 3 speakers will give us a different perspective how we can use AI to improve primary healthcare systems. In this session, we will explore the fundamentals of how AI works and its real-world application in primary healthcare, share practical lessons from implementations, particularly in low-resource settings, and also we'll examine the balance between risk and reward, including the enabling condition and ethical considerations required for responsible use of AI. We will conclude later on with question and answer sessions. After the presentations, we'll have a time for question and answer, which will be open for all of you. On the process, we will have the 3 presentations. We'll be starting with Dr. Qingfeng Li from Johns Hopkins, who will give us an overall on AI, and then we'll continue with the 3 presentations. If you have any questions, please feel free to write some of the questions. But after the 3 presentations, we will have time for question and answer, and then for all your questions, we'll be responding at the end of those at the end of the presentation, the 3 presentations. So just to introduce our first presenter, I will turn by turn. I will introduce our speakers. The first speaker is Dr. Qingfeng Li. Dr. Qingfeng Li is an assistant professor in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. He is trained in demography and statistics and uses advanced quantitative methods to address diverse public health challenges, including injury prevention, maternal health, and health systems strengthening. His methodological expertise includes data science, artificial intelligence, and health system science modeling. Dr. Li has extensive experience in the design and implementation of large-scale mixed method studies, as well as in the analysis of complex data systems. His work emphasizes the triangulation of primary and secondary data sources, including big data sources, to inform public health research, policy, and then practice. Thank you so much for joining us, for making time. Now I will take it to you for the first presentation. Thank you so much, Dr. Li.
Yes, thank you so much, Professor Tilahun. So for that very nice presentation, and welcome all to today's webinar. It's very nice to talk to you about my research using AI in primary care, but more generally on health system research, which I'm based right now. Like Professor Tilahun mentioned, I'm a assistant professor at the Department of International Health at Johns Hopkins University. I've been working on data science and AI for the past number of years. And then today, I think I have about 10 to 15 minutes to briefly talk about my recent research using AI. So I think we have a pretty large audience today. I see over 200 people. I guess we come from different backgrounds. So just to define the terminology, so people use AI to refer to different things, right? People are using AI to cover basic rule-based AI system or even statistical regression and some others. So for today, I think my use of AI have been clearly focused on so some of the deep learning, but also the traditional statistical methods. So so given the limited time, I'm not going to talk about the technical term, but use the example. Here we publish a paper a number of years ago on using it's the people don't consider this as AI. So although broadly, as you can see this from diagram, it is an AI, is an AI rule-based system. We call it a rule-based system. It's just a bunch of if else. If the child have this condition, then the cause of death is this, right? And then I believe many of you are physician or working in clinics, right? I think that is how human works, right? We see different condition of the sick child or even the diseased child, and then want to determine the illness or the cause of death. So we develop a standardized computer algorithm to determine cause of death using this data. I think a lot of people are working using this methodology, and also if you are not using this explicitly, you may be using that in your mind, right? The certain condition match certain cause of death condition, right? This is the traditional way, or again, some people no longer consider this part as AI. And then some paper, not by me, but by other people using AI, more modern or advanced machine learning algorithm to apply to the same problem. You can see AI is able to achieve better performance. You can see some of the measures here. They're using accuracy, but as you know, you can also evaluate AI performance using other parameters like precision, recall, right? I think you can see AI doing a pretty good job on classifying this disease, right? Some of this accuracy is 95% or 96%, 90, even higher. I think is maybe comparable to top physicians, right? For some of the conditions, according to this paper. And then recently, we have been using AI, also the advanced AI technology to classify maternal morbidity. I believe some of you also work with prenatal or maternal health. So as you all know, that a small proportion, but very importantly, a small proportion of women will experience severe maternal morbidity during delivery. So we want to predict that when they enter hospital. We are using the data from the US, but clearly it can be replicated in other settings if you have the data, right? When women get admitted to hospital, we use all the diagnosis and also all the socioeconomic indicators to classify the woman if the woman is more likely to experience severe maternal morbidity. And then I have to say that our model performance is not so great. So for a number of reasons, if you read our paper, first, we may not have the variable to classify the woman, and also we may not be using the best algorithm. So we are continuing this effort. So those are just the three examples. I'm also using some other part of AI, such as computer vision. Some of you know that has been applied extensively to other areas. So my major research area include maternal health, but also injury prevention. I've been using AI computer vision to detect risk factors on the road, which I know is very different from many of your areas, which is primary care, right? So we use AI to estimate vehicle speed and also to estimate or to assess situation on helmet wearing. We actually, this project also cover Addis and many other countries in the continent, many other cities in the continent. So that is another interesting use. So that is basically my work. And then more broadly, I think I'm using some of the pillars of health system as example. You can see, right, the potential of AI. We are working on some of this, but still we haven't finished, right? We are developing, for example, using AI assistant to assist the policy making on, again, traffic safety, which is another area, but I think you can also do this, right? Once you have the data, the evidence, You can train that to train a personal assistant to policymaker, to stakeholders, right? And also you can see some of you, I believe, are working on this, right, using AI to deliver service. We are also starting to work on this. On the right, you can see an interview with Bill Gates, right? They are using a AI device to for antenatal care. So, and also this is the area I've spent a lot of time on, using AI to integrate the many kind of data sources, including EHR, electronic health record, and other traditional or unstructured data, voice, video, so that we can put them together. You can use the more traditional natural language processing, or you can also use the more advanced large language model, right? So yeah, this is the basically my work, and also my published work, and also existing work, ongoing work on using AI for different kind of health system research. And then, but I think I really believe moving forward, just from some forward reflection. So I think moving forward, I do see some great potential using AI for health system research, including decision making, service delivery, and particularly health information system, right? And also, but here the challenge, as you all know, that current AI development, particularly the AI large language model development, is highly concentrated in the US and concentrated in the Silicon Valley. It's and also highly concentrated in a small number of companies. And then clearly our area, public health, is not their top priority, right? We don't have so much commercial value to them. That's why their value, right? If you use GPT, for example, out of box for your purpose, it may not the best for you, right? In the moving forward, if you want to use GPT, first you may want to fine tune, or you may want to further do some post training and also evaluation, right? That is just the challenge. We're also working on that to train our version of AI system that suit our purpose. But clearly, hopefully there will be some spillover effect. That means the model developed for other purposes, we can readily use them for our purpose. That's a very brief introduction of my research, and also my reflection, or my thought on the future. So I'm not sure if we have time for question now or later. Back to you, Professor Tilahun.
Thank you very much. Thank you very much, Dr. Lee, for the great presentation, especially on how AI is being used practically with practical examples, as well as the potential areas in low middle income countries. Thank you so much for those insights.
Yeah. So yeah, maybe just to mention, right? I think yeah, just follow up on the words you mentioned, practical. I think I am very practical person. I think as you all know, right, there are a lot of discussion, a lot of excitement about AI using more advanced, right? Even the large language model. But for me, I think there are a lot of low-hanging fruit, very low. I think so that because you see, although despite the excitement, the real-world application of AI for real-world policy making and also evidence data collection, data analysis is still limited. So I think yeah, so I think I also yeah, I deeply believe in being the practical, right, practical side. So kind of practical application, not just the fancy ideas. Thank you.
Yeah, great. And also, like, for the paper, we call it AI, you're doing different modeling and also how it can be used. So I read one of the paper, quite interesting. Maybe we can also later share for all the participants here, so that they can also read those papers. I didn't see specific questions, but if there are any questions in between, we will be inviting you. So thank you so much for the great presentation. And then now maybe we can move to save time to the next presentation. So our next presentation will be by Dr. Ruta Israel Mehdi. Dr. Mehdi is a medical doctor and a health data scientist specializing in the intersection of clinical medicine, epidemiology, and high-performance digital architecture. Currently serving as a technical advisor to the Ministry of Health in Uganda. He leads the development of the national scale business intelligence platform and the automated data pipelines. With a technical toolkit spanning Python and R, Dr. Mehdi has a proven track record of architecting AI-driven solutions for pandemic preparedness and optimizing community health information systems for international organizations, including for UNICEF, USAID, and JPIGO. Once again, thank you so much, Dr. Mehdi, for joining us. I'm sure as you are having a lot of experience working with the government, I think you'll share us your experiences as well, how AI can be used at a primary care level and also the governance aspects. Once again, welcome, and then the floor is yours. Thank you, Dr. Mehdi.
Thank you very much. I hope you can hear me, and I'll go straight
into it. Well.
Yes, it's a national obligation to give a quick introduction to the country. I come from Uganda. The Pearl of Africa is located there on the map. We have about 53 million people. The average age is 16 to 18, and the official language is English, and we have over 8,000 facilities. So this just gives a broad overview of the current digital health structure for the country, so many systems. And on top of this, we hope to leverage innovation and artificial intelligence to bring services closer to people, but also ensure that there is quality and support for the people who deliver the services. Now, going into the specific use cases. The first use case that I want to share here from Uganda is ensuring diagnostic integrity at the last mile. And this is the background. Part of the PHC efforts in the country and on the continent is driven by community health workers. And these do provide promotive, preventive, but also curative services. And some of these are done through delivering diagnostics. For example, for malaria, which is one of the leading causes of death and morbidity in Uganda and the continent. So we know that millions of these RDTs are used in the communities, and they are used by community health workers to provide services closer to underserved areas. However, there are issues related to data, transcription errors, what the community health worker sees and what they transcribe, interpretation, and also data reliability. And this has implication upstream of how we quantify the burden of malaria, but also how we use the treatment that stems from these tests. And with the support from the GATES and through MEDIC, we thought that we can have AI tools improve the accuracy and do quality control and standardization of this testing at the community level. And how we have approached this is in a phased manner. So this is being done in Uganda and Kenya, and it's being done in a study setting. We chose districts, organizational units, 4 of them in each of the countries, and we've compiled a protocol that was reviewed by the REC and the Uganda National Council of Science and Technology that is sound and can deliver to the objective of evaluating the impact of integrating an AI-enabled digital malaria RDT reader into the community health information system. And we have some objectives we are curious about. One of those is to assess whether this does really improve the interpretation, if it does have effects on the testing volume, if it's accepted by the users, what are the barriers, but also what are the costs and what are the potential savings of scaling this up. So this is one of those use cases where Uganda is taking a deliberate scientific approach to roll out some of these AI interventions in the country. And this is already ongoing, and we are already seeing some of the results come in, and we hope to use those to inform whether this should be scaled up. Is this hype or there is actually some sound proof of real impact beyond the algorithm. The second use case is dashboards to decision. Around the pandemic, we had also an explosion of visualizations and reports and dashboards, and there were so many. There were in thousands, and different managers for health at all levels had to struggle with login credentials and systems to navigate to get some basic decisions for planning PHC delivery. And working with the US government through JPEGO, the team at Ministry of Health has consolidated all these dashboards and reports into one platform. But that has brought a new problem. And it's one of the things that the previous speaker talked about. How do we leverage on some of these new technologies, like some of the software that does natural language processing to SQL, to ease the retrieval of data, so that the people who need to make these decisions for the delivery of services and optimization of resources don't have to click 7 things and apply 9 filters for them to find out which particular village has the biggest need. And what we are doing here, and that is a problem I've described, we have so many reports and dashboards across all categories, and users have to have some specific time and knowledge and patience to navigate these. And if you are beyond 2 clicks away from an answer in a world where people are extremely getting which district had the most maternal death in the previous month, and they can see this and proceed. No report hunting, no filter guessing, just natural language, and then proceed. And it's being run in this way. You just ask a question, the AI does the initial understanding of the intent and passes to SQL, and then that is given to the server, which retrieves. Now, so this is a screenshot of what this looks like. Even if you have typos, you can just ask, and then you get the information. But how we are doing this differently is how this is being rolled out. So we are not initially targeting users who don't understand the structure of these elements or can hear me. We have electricity issues. Yes, so this has been done with the intent for M and E's. So we are hoping to use this for people who understand the data, not people who can validate the data. So we give a snapshot of the actual query that has been generated and how the measures are going to be calculated, so that someone who understands has an opportunity to look at this and say, oh, this is not right, or this is right. And the end goal is this, that we can use the initial implementation, because we are logging all the interactions, that can give us templates. We have this theory that maybe 70 to 80% of the questions can be narrowed down to between under 10 templates. For example, you can see questions that are in this structure. And if we can just generate enough information with these initial LLMs, we can move away from that and actually do this in a more organized way. But we need the AI to understand the demand, and we need the initial deployment to train. So that is what is being used for, to more distill information, but not as a mainstay. And so in summary, I've given only 2 of the use cases that we are having in Uganda, and it's clear that there's a lot of potential for AI in this space that we are in, and I think we are behind other industries. but we have to be cognizant of the difference that this particular industry holds, and that is the health of the people. And we need to prioritize the safety over technical novelty, and we need to have gatekeepers. Health workers should validate the M&E, or other technical people should validate, and the adoption of these methods should be done through a sound process that has gone through the due processes of science and can be replicated. And there's sound evidence that before these were scaled up, they actually yielded some benefit. And we hope that we will scale solutions to the people, not just algorithms. Thank you. And sorry for that initial power surge.
No problem. Thank you so much, Dr. Mehdi. That was really a great presentation, and also great to see all the practical things you are doing in Uganda as well. And also, I'm glad to see how you are considerate of safety as well as scale for AI, which are very critical in the AI area. Yeah, that was good to see from those slides. I think we'll be sharing those resources as well. And also there were some questions which are coming for you as well as for Dr. Lee. Maybe we can take a few minutes because Dr. Lee is here until at the top of the hour, so we can take some questions, discussions, and then we can go to Dr. Tamana later for the start presentation. I can see, Dr. Lee, you have been responding on some questions, but from the questions which were posted here, if I can come to one of the questions maybe which was being posted here. There are different questions, and then one of the question was, we can see there is a lot of potential of AI, but how we can make sure that it's like being scaled and then being used at the health system level was being asked with by different participants. Maybe Dr. Mehdi, do you want to say something because I'm aligned with your work? For those of you who have more questions, can you post on the question and answer section so that we can they can respond? Thank you. Back to you, Dr. Mehdi.
Yes, but do you mind repeating the question?
The question is, we know like different like works are being done in AI and then how it's being used in the health sector. So what's your perspective on like how we can scale it, as well as, if I can add, like how the government can handle the governance aspect, because you also work with the Ministry of Health. If
Yes.
you can like share your perspective on that.
Yes, thank you very much. So the first part of the question is, and this is my personal opinion, I think AI does not give us a shortcut to the ready processes we have for adopting solutions in health. We have a sound process that we go through. We have existing regulations that does not exempt AI. So we can start in a small setting, collect data, and then move up to more non-biased studies to generate some evidence that there is actual utility before we subject a lot of client data to these algorithms. So the first part is we need to really do this in a phased, rigorous manner of scaling up these, especially for health. And the second part, I think there is a lot of opportunities in government because no one can afford the scale that government has. Government has a scale that surpasses both in geography and time. And even the little progress that you make with government is much more impactful than a lot of progress that is made on the parallel side. So it's extremely important that we don't give up on governments, because sometimes government seems to be very procedural, but we support governments to and be able to move into the new generation. So let's not give up on our governments. Let's invest in our government and support our governments to catch up.
Great. Thank you so much for that insight. So just to follow up, As well, there are some questions which are coming from participants. If I can ask the question is, if you can see from the question and answer, Solomon and Brooke, they were having some questions for you. So Brooke, Diana was saying, what skills should primary health care workers develop to effectively use AI? And also Solomon was asking how we are, as Africans, planning on using AI models for clinical decision making, specifically as those questions are in alignment with your presentation. Maybe can you share your perspective on those questions as well? Back to you, Dr. Mehdi.
Thank you very much. I'll begin with a question of Solomon. That is the bias. I think we really have a lot of gap related to locally generated data, and that puts us at a disadvantage when we try to contextualize some of these models that do exist without giving that. So we have an opportunity to try to organize our data and share data. And I see there are a lot of decision makers across this platform from different countries. So we need to support the open source endeavors for sharing data. I know the East Africa community has tried this within the region, but we need to take this on as a continent and share data, and also support to provide data for the innovators in the continent that are trying to fine-tune some of these models so that they reduce that bias, but also make them more relevant to our context. And the question of the skill that PHC workers, I think we have the easiest one to start with, that is building basic ICT skills. That is a starting point. We have gaps within PHC workers, specifically community health workers, who have not used any technology in a long while, or who are just starting to use a smartphone. And that is the first place. Even before you think of AI, they need to first catch up on the basic ICT skills, and then that will position them to tap into the opportunity that AI provide. Over to you, Prof.
Great. Thank you so much, Dr. Emedi. That was very insightful. And also there are other general questions which are coming, but later on the question and answer, you'll be responding on those, and then really want to give you time for water as well. So as Dr. Lee will be leaving like in 20 minutes, you might not be around during the other question and answer. Maybe if you can take some questions for Dr. Lee now, and then move to the next presentation. So there are some questions, Dr. Lee, which are coming for you. I saw you are also writing on some of the answers, but if you really want to voice over some of the questions, I was looking at, someone was asking about the model bias and then how it works. Others were asking about what kind of metric, and also what kind of metric and then how we can measure it. As well as there were additional questions you are responding. Do you want to come over and then voice over before you leave us? Back to you, Dr. Lee.
Yeah. Thank you so much. I think some of the questions are pretty similar. I think one is how to evaluate the model. I think the paper I just showed use accuracy, which is not always the best matrix. I think there are many other metrics, and then the metric evaluation metrics have to depend on your research question. Sometimes precision is better, sometimes recall is better, sometimes F1 score. But I think you have to decide that based on each specific data property and also your use case. I think that's why it's pretty tricky to develop a model. And also on the real world deployment, I think, again, I also in my slides and also in my responses, I repeatedly mentioned the word potential. A lot of people get very excited about the future of AI, large language model, and how that's going to transform our work, our life even. But I think, but the real world deployment is really challenging. I can see a lot of barriers. For example, right? I don't think you can take a GPT to some remote area where the service is most needed, and then how to localize, how to use the edge computing, right? Make the model small enough small enough to fit your personal phone, tablet, that is a challenge. I think, again, a lot of potential, but again, I'm a very practical person, and how to actually use that to right to assist policy making at the local level. That's the challenge. Thank you.
Thank you very much. Thank you so much. That was really a good reflection on those questions. And then there was also another questions which are coming. If we can get your perspective, Professor Getnet was asking if you can ask, how do you see AI in 5 years? And then Talawan was asking, really, in Africa, can we have our own local AI data set as well? Maybe can you reflect on those generic questions as well? How do you see AI in 5 years from your expertise?
To me, okay. So yeah, I'll give my personal reflection. First, the development of AI is pretty stochastic. That means there may be some great breakthrough in the next year or in the next few months. I think that is not sure, right? You can see over the past few years, AI has been developing very quickly. So that is one thing on the AI part, but I'm more interested in the people's part, how we can, right? I think some question ask how people, right, in those low resource settings can actually use this. I think how we can learn. So I think I'm teaching a course at Hopkins on using AI for health system research. I think currently the technical bar for using AI in your real work, in your actual work, is much, much lower because of the system from GPT or from many other tools. I think in 5 years, I hope, on the AI part, I hope there is some new technology, new algorithm development that make it even easier to use. I'm not sure how likely that, but I really hope on human side, everyone on this room or even people who have the potential to benefit from this wave of large language model AI could learn something that we can equip us better to use AI to take advantage of this revolution, if it is really a revolution. It's us. It's upon us to make it a revolution, right? The technical development itself is never going to change anything, right? We have to adopt it. Thank you.
Yeah, that's really a great perspective. And just following up on that, there was one interesting question from Bubnet, in which maybe we can say in AI, in machine learning, in deep learning models, there are different models which we are currently using. So the question was, most of those models, they are trained using data from different countries, and then data from low resource settings are not always used to train those models. So in using those approaches, she was asking about the fairness of like how we can use, what kind of data we should use to train those models. Maybe can you give your perspective on that very important question?
Yes, it's a very important question. Like I mentioned, in the past few years, the development of AI is highly concentrated. 80% of AI development occur in the US. 80% of those in the US occur around Silicon Valley. So it's highly, and maybe 80%, just a small number of companies. And then they use Western dominated data in English. And also, I think because that's where they can get the materials, right? Material for train the model. That poses a huge, I think, risk, maybe potential risk for its application to other settings. For example, to Ethiopia, right? I don't think the materials from Ethiopia account for a large proportion of their training material. That means the model, right, is customized, optimized for the Western setting. That's why when you use this model, again, I repeatedly mention the word evaluation. You need to evaluate the model and make certain fine tuning to make it proper, appropriate for local setting.
Right.
Thank you.
Once again, thank you so much, Dr. Lee, for your insight. Thank you so much for your insight, as well as for your responses for those very interesting questions from your ample experience. So thank you very much, Dr. Lee. Now we can, to effectively use our time, we can go to the third presentation. So our third presenter is Mr. Tamana Faisa. So Mr. Tamana is the director of the digital house at Last Mile House in Ethiopia, where he leads the design and implementation of innovative solutions to strengthen community health information system. With over 24 years of experience in ICT and digital health, Tamana has spearheaded Ethiopia's most significant national projects, including the ECHIS electronic medical record systems, the National Data Health Blueprint, and also a pioneer in health tech. He currently oversees cutting-edge initiatives like HEP-Assist, an AI-powered clinical chatbot supporting health extension workers across the country. Thank you so much for joining us this afternoon. I'm looking forward, like we started with a general presentation from Dr. Lee, and then an experience from Uganda. Now we are going to a very practical experience in Ethiopia, especially on how we can use AI to assist health extension workers in Ethiopia, which I would say is quite interesting, and then a big potential we can expect AI at a primary care level. So thank you so much for joining us, and then the floor is yours, Tamana.
Thank you very much, Professor. Can I be heard? Maybe my
Yes, we can hear you well. Please go ahead.
Okay. Hi, everyone. This is Tamana. So I work for an organization called Last Mile Health. Last Mile Health operates in 4 African countries: Liberia, Sierra Leone, Malawi, and Ethiopia. So in Ethiopia, we partner with government, the Ministry of Health, and especially we work on the community health. So as community is one part of primary health care, so I'm gonna present our practical implementation of AI and the community health, specifically for solutions for health extension workers, community health workers. So these are my content. Before I say what the challenge, before we get into this AI solution, as Last Miles for the past 4 years, we've been implementing some digital health solutions, primarily mHealth. So we have developed a solution called Extension Essentials that upskills community health workers. So with the implementation of Extension Essentials, we are able to reach about 25,000 community health workers nowadays. So it's out of 40,000 plus health extension workers. We have already covered more than half of them. So while we implement this, we have noticed that with the practical data that I'm gonna present here, as you can see the figures, we have evidence that there is low clinical confidence among health extension workers, which undermine case management, clinical case management. So this is actually a data that we have, or a survey that we have conducted while we have provided these trainings nationwide. So 34% of community health workers can correctly classify the correct case management. We have also observed that when it comes to resource feasibility, there are bulky, outdated, and difficult to navigate materials. So they lack the appropriate materials for references. There is also a disintegrated support and lack of real-time consultations. And we have also observed that 55% to 87% improvement in post-training when it comes to sick child management. That means community health workers or health extension workers mostly struggle when managing a sick child, as the data reveals. So this has made a consequence of fear of incorrect treatment, low confidence in health extension workers in case management, delayed decision-making, and unnecessary or missed referrals are some of the observed consequences that community health workers do fail. So we have designed a generative AI, an innovative an innovative solution, generative AI solutions that we have developed, co-developed with the Ministry of Health. So it has got 2 stages. Now we have implemented for about a year. So the first stage is implemented in such a way that the community health workers do get consultations through a call center where an agent, when I say there are health center-based health workers like nurses, midwiferys, and professional HOs are assisting the community health workers and using the AI itself. So in this stage, the health extension workers do not directly use the AI solution that we call HIPAA Assist, but it is through consultation, through call center. In a second stage, we have made this solution accessible by the community health workers themselves, because in the first stage, the idea is more of evaluation. So there are challenges or gaps in directly implementing these HIPAA Assist for health extension workers. There are many barriers: language, connectivity, and judgment of digital health use of, digital tool use of the health extension all contribute to something that we think of these community health workers do use through the call agent. But at stage 2, when these gaps are somehow fulfilled or somehow these gaps are minimized, then the aim is to export this health extension workers to directly use. Let me invite you to watch a 1 minute or 2 minute video to make you just get the overall.
In rural Ethiopia, health extension workers are the backbone of community health. But sometimes, even the most dedicated face complex cases, needing guidance, reassurance, and immediate support. Imagine having a trusted colleague always by your side. Salam, I'm Hawa, your AI assistant. I'm here to support health extension workers like you every single day. I have been trained on all health extension worker packages, whether you are working on maternal, newborn, and child health, or focusing on nutrition, hygiene, swine patient, disease prevention, family planning, or community mobilization. I'm ready to help. Come this way, please. Don't worry, we will help your little boy. Thank you. Thank you. He is so hot.
Does the fast breathing be due to pain or pneumonia? What additional assessment can I do to the child? Should I do RDT for malaria? Should I give him paracetamol first? Which guide should I refer?
Hawa, can you support me making this decision? Of course. Please ask your question. I have a 3-year-old child who came with fever. When I evaluated him, he has fast breathing and fever of 39. What should I do for him?
First, rule out presence of any danger signs. If not any, take cooling measures such as taking dextraclose and cold compression to reduce the fever. Do RDT for malaria. Provide paracetamol based on the child weight and reevaluate for fast breathing and pain. Treat the child accordingly based on the result of your reevaluation and malaria results.
And come back next week for the check. Thank you, I will.
With HIPAA Assist AI, the support is just a whisper away, empowering you to make clinical decisions with confidence.
Okay, so as you can see from the video, Hawa is an avatar, as you can see, a trained health extension worker on AI. So the idea is Hawa playing a character of health extension worker here do support in the real time support these community health workers here. Okay, the blueprint. So prior to developing this solution, the HIPAA Assist, we have gone through different kinds of content structuring and expert engagement here. So the design itself have engaged 26 MOH program specialists. So they almost led the content design. So as to the scope, it has a defined scope. So experts identified and compiled essential guidelines, protocols, learning materials within the scope of practice of health extension worker. As I have said, this is a generative AI tool. So when it learned from that of these protocols, learning materials, guides, all these. So it won't go outside of these local repositories that are compiled by the Ministry of Health and approved by the Ministry of Health. As a tired information, so this Ministry of Health documents are categorized as basic. That means need to know by the health extension workers, and we have had some reference documents and extended knowledge to boost their knowledge. As to the interface or the HEPASYS interface, we have developed or enhanced the tool based on the expert feedback. So the AI now uses such kinds of a good content formatting like bolding on bullet points, all these with clarity, emphasis with critical clinical actions, and allow the users to toggle between basic and reference documents. As to traceability, the system displays linked citations for every responses to ensure transparency and strict adherence to Ministry of Health resources. So for each response, the LLM response, the users do have access to the source document so that they can even open or download the source material that's referenced by the AI. The core technology that we have used, actually, at the beginning, we have implemented this with the open source, taking into consideration that an open source tool do survive maybe when it comes to, ownership and the government cost and related things. So we have chosen open source models. For this sake, we have implemented a Llama with this number of parameters. But now currently we've been switching to lightweighted, open weight models to make that it's one, not resource intensive, that we can host on-premise and within the Ministry of Health infrastructure. And with this now switching to lightweight models, and actually we begin with that of this large language model Llama. So it utilizes retrieval augmented generation, RAG. So it means that the knowledge base is limited to the source materials that I have mentioned earlier. The Ministry of Health's guidelines, training guidelines, chart booklets, and training material all are now used to train the LLM. To ensure the responses are grounded in verified document rather than assumptions, this is also considered. The infrastructure, we are now hosted on the AWS infrastructure because of some resource limitations in country, but we are still planning to transition it to the local or infrastructures as available, and we are communicating with the AI Institute for this. Localization, the capability to support both text and voice interactions is made. Major language Amharic, Afaan Oromoo, and Tigrinya are also supported. Voice to text capability is now tested and is already implemented, but our goal is to implement full voice to voice feature. The functionalities or the features of this solution, so document management, the ability to upload, categorize, activate, or deactivate documents. So this is important because, each time there are an updated guidelines from the ministry, then it does not need experts. So people at the Ministry of Health can easily upload the updated manuals or guidelines or protocols, then can activate or deactivate the outdated information. So with one click, it will enable this activator and referenced by the LLM. The modules and the programs, we have tried to integrate about 24 programs and 18 health extension worker packages are all integrated in. So it has both user management, multilingual support, feedback collection systems, surveys and user feedback, and it of course supports multimodal support like voice to text, and as an output image as an output is already implemented. Okay, in consideration to safety, we have built a multi-layered safety for accuracy and reliability. The first one is the use of RAG, because RAG limits the knowledge that this LLM refers to be to the local knowledge base. So in doing this, we have somehow minimized hallucinations. So the boundary control, anti-hallucination, verifiability, real-time guardrails, all these are the capabilities that we gain through RAG. Machine validation, automated safety. We have also added a feature where it can be enabled in the admin settings, where an LLM as a judge is already there. So we have another LLM that judges the output of the first LLM to minimize hallucinations as much as possible and flag hallucinations. So we have conducted also enough regression testing in a house before we have implemented this. As to the human validation, other validations that we have done with the clinicians, about 3 tiers of validation, expert validation that we have conducted with a different level of engagement with the Ministry of Health experts, so that the solution is well aligned with that of the national standards. Operational, we have also conducted this validation with call agents that verify the AI device during consultation. That is why we have needed these call agents as a human in the loop, just to minimize somehow or to get some feedback, while they provide consultations to the health extension workers through call. Field supervisors to also cross-check guidance in the real world use. Especially, we have implemented this help assist supervisors, where when it comes to that direct use of the AI with the health extension workers themselves. So regarding the reach, we have implemented this help assist in 7 regions, covering 15 waradas. So the total health post is about 282 with an estimated population of 1.5 million. So with the stage 1, so call center, we have reached about 628 community health workers and with 30 call agents. As to the direct use, we are now currently testing this with within 3 regions with a total of 32 health extension workers. In this case, we have about 3 supervisors are assigned. So it means that we are just moving towards a direct implementation for health extension workers. So what's the observation? Through the call center, there is a high call volume, about 18,478 incoming calls that we have received, but much of this, in average of 3.2 minutes, successful calls are made. So with these total calls, not all of these calls are answered. Some are abandoned. Some calls are not answered. It means then among the answered calls, about 6,555 consultations have been made by the call agents. So among all these questions or queries that are coming from health extension workers, the most questions, as you can see here, there are questions regarding child health management, diarrhea, fever, family planning, abortion, all that you can see here on the screen. All those are queries, but among these queries, the most dominating one is child health. Most common topic, about 5,400 entries are observed with the child health. That means that the health extension worker still struggle in the child health care. So the most ones are diarrhea and fever, so you can see here. So patient management and the complications, high demand for practical treatment guidance, including managing side effects and the complications. Infectious diseases like malaria, TB, and HIV are also the most query that we have received. Women health like ANC, family planning, and pregnancy, danger signs, contraceptives, all these are also some query that we have received. So among 10 programs consulted, as you can see, among these 10 cases that we have rated here, about 10 of this, diarrhea is the most one. Next, pneumonia comes in the malaria. So it is a high number of consultations for diarrhea, pneumonia, and malnutrition reflects the potential gaps in WASH, household nutrition, immunization coverage, and early care seeking. So 88% of consultations focused on case management. That means that the health extension workers commonly ask questions that are related to case management. Only 11% are general questions that they ask. So among this, 53% of these cases that they have reported is treated by themselves in consultation of the co-legentists, and only 37% are appropriate referrals that they have made in consultation with that of the co-legentists. As to the response or the response rate of this HEPA assist or the AI itself, the AI response time look like this. Fast, most of the time, 98% of responses do show that it's acceptable. The AI is answering almost in 8.6 seconds as measured by the system time. So of course, this depends on the use of local language or not, the complexity of the case or the server capacity or other factors. So what have we learned? So the learning, scaling digital health to bridge the clinical confidence gap is feasible. So we have a strong demand. We have observed a strong demand for case management by the health extension workers. An average of 8 consultations per health extension workers in 2 months period is observed. So increased accessibility, digital health solution like APAS also increase the accessibility, reaching the equity when it comes to access to materials or resources or access to information. So all these low clinical confidence that I have stated earlier, the high call volumes that you have observed, and the maternal and the child health focus accounts for 48% of consultations. All these are what we have learned, and based on this learning, we are still trying to enhance this solution to best suit the need of the health extension workers. As to the directives that we have implemented recently.
Sorry for the interruption. Can we conclude in 3 minutes so that we can give time for the question and answer as well? Thank you, Pandana.
Sorry for that. So, as I have said, we have now directly implemented this solution in 3 regions for 32 health extension workers. So this time we have implemented localization, so health extension workers communicate in their local language. And we have also implemented a voice input, and so a kind of voice to text feature is now supported, and the health extension workers can directly use direct interaction with their local language. As you can see, the health extension worker is interacting with the HEPA assist with a direct speech, not typing anything, but communicating in Amharic, and then the HEPA assist retrieves documents in this local language and get back to her. So we have more testimonies that I can present, but let me, due to the interest of time, I will not present this one. And we have real testimony that the health extension workers themselves and the collegians have provided. So as to the challenges, I'm just finalizing. So what we have observed as a challenge or as a gap is one, there are variable consultation quality. The effectiveness of the consultation is highly dependent on the individual provider's expert of knowledge. This is through the implementation of call agent, but in the future, we will not implement this through a call agents or call system. The health extension workers should directly use, but we have observed this challenge. Reliance on human factor, system operation is constrained by human availability. These call agents are part-timers. They have other engagements. They do some OPD tasks themselves, and then there is somehow a gap in availability. Language barrier, as I have said, there is a language barrier with that of the lack of LLMs with inherent understanding for local languages. Up to now, what we have used is translator models like Gemini for the local languages. But in the meantime, we are seeking for these lightweight open models that inherently understand Amharic. We are just transitioning to models like Gemma 3 with some capabilities of understanding Ethiopian local languages. Connectivity is another barrier that we have observed. And hosting, as I have mentioned, local hosting with unavailability of GPU machines in country, this is also one gap. The governance issue, since AI is something that we are now implementing in Ethiopia, especially in the community health, we have observed that governance frameworks and the like are still premature. Funding, just to reach these 40,000 community health workers, of course, needs much funding. As to the next step, we aspire to scale to reach 40,000 health extension workers. We are now at the beginning, but we are planning to reach these 40,000 community health workers. We also try to continuously improve the solution, especially with this voice-to-voice feature and offline capabilities and clinical accuracy, everything. We are working toward that. The localization, as I have said, to enhance local capability of the major languages. The integration with tools like Essential and our ECHIS is also basic. Now we have already made some integrations with Extension Essential so that we cascade it with that of this training tool in the future, so that it will be sustainable and reach fast. The offline support, as I've said, we aspire to increase accessibility through enhancing offline capabilities. We use to evaluate small language models to fit this purpose. Thank you very much. Sorry for the time that I took. Get back to you, Professor.
Thank you very much, Mr. Tammana, for the great presentation. And it takes more time, but it was quite interesting for everyone. So I'm glad we're having time to hear about this great work. And also, I think for myself as well as for everyone, it's great to see AI work at this level, even your at scale, implementation at scale, which is quite interesting because at the healthcare settings, we don't have a lot of AIs at scale. I think that has been really a very good experience, and I think everyone from the text as well, everyone was appreciating the great presentation and also for sharing this. Thank you so much. So just quickly, I think from the question and answer you're presenting, you might not see them, but most of the questions were, does it support local language? You already addressed. It supports setting the major languages like Amharic, Afan Oromo, Tigrinya. That's really great. And then one of the repeated question was really what kind of robust evaluation was done, and also really in terms of looking at the ECHIS, the platform itself, because the platform have some of the functionalities of ensuring those kind of supports. So what kind of unique additional value you see because of the help assist? I think those were some of the repeated questions. Maybe can you reflect on that before we go to the question and answer? Until you respond, if there are any questions, in 3 minutes we'll be going to the question and answer. if you have questions, if you can write, the panelists will respond. But until then, you can respond on the general question I just posted. Back to you.
Thank you, Professor Bini. So I think for the question, as you have said, please track it for me because I didn't see the questions on the QS. So the question regarding the evaluations, the robust evaluations. So we have conducted some consultative workshops and evaluation workshops, many rounds, of course. At the first stage, we have done this with 19 experts from the Ministry of Health that represents the different programs. So we have these questions, or about 590 questions that they themselves drafted. Then we have made it ready, the platform for them for the evaluation. Yeah. Then some of the evaluation reports are not presented here. Sorry for that. But the results of this evaluation was so encouraging that we have moved to the next step. So we got a green light. So we have evaluation metrics like accuracy, relevance, completeness, like safety. All these things are included. Then the results were very encouraging. This one is the first one that we have done an internal test. As for the external test, human test, now recently, even currently, we have invited external evaluators. So if you know or not, I don't know, there is a popular MOVE platform, MOVE by Light. So this is from Harvard. So using this, they have their own independent evaluation metrics that they themselves develop. So using these evaluation metrics, we have also tried to do some rigorous evaluations with in consideration of about 8 metrics. So maybe the result is not disseminated, but actually we will have a dissemination event in April that we're gonna present about this one. As to the maybe what makes us different from ECHIS is that the duplication of effort or something like that I have mentioned. So as a man or as a person that was engaged in the ECHIS development, and even I was a focal person for ECHIS, the Ministry of Health, I feel that ECHIS is a rule-based, deterministic system. So of course, it is quite reliable to use ECHIS for community health workers, but at the same time, if you take ECHIS, you have to navigate all through the wizards. If you treat child health, you have to go through that. If it is API, you have to go. There is no way, or I can say that in a kind of aggregated, or maybe let's say it's an open question like a 2 years old woman, child came to a health post having these, that complications. Maybe with disease or maybe with that of other interdependent or programs or even not interdependent programs. ECHIS lags, because with these generative AI solutions that rely on standard protocols and guidelines, all this one, the generative AI can create content. So it's generative, it means that from these learned materials can cross-analyze all of the possibilities of this case management that can decide and maybe reflect back to the health extension workers. Yeah.
Thank you very much. Thank you so much. That was very, very informative. And I think on the question and answer, we have several questions. Maybe I can call as well Dr. Mehdi for the question and answer session. We have several questions, but I think Taman, if you can take some time to breathe, I can call upon to Dr. Mehdi. I think you have been looking at the chat as well. So from the chat, from the questions, you're trying to respond some of them by text. But if you can voice over, I think from what I see, I can see some of the question from the lack of data set in Africa, and also the skill gap, infrastructure, resistance for technology uptake among health workers. And also there is one interesting question from Kadia from the government perspective as well. He say, based on the research and the practice, are there any concerns around long-term sustainability of AI systems, and are governments receptive to local hosting needs of long-term? How can governments start to buffer the potential of long-term barriers so that we can leverage AI? That was also a very, very important question, which was coming from the participants. So from the questions you have been looking at, and also from those I just posted, Dr. Mehdi, can you give us your perspective and then some of your take?
Yes, thank you very much, and thank you for the presentation, Tamini. So three things. One, data, and if we are to benefit anything from this whole AI hype or revolution, we need to organize our data. And that is some of the work that we have done in Uganda, but it's some of the work that is being done in the region of East Africa and also as a continent. We need to move beyond the rudimentary paper reporting and aggregate reporting to support client level reporting. I know most of the colleagues here have interfaced with the EMRs, with ECHIS, but that is where the future is. We need to organize those systems, we need to warehouse the data, because the more the data is organized, the more the data is speaking to the reality, the easier it is to use some of these algorithms or systems. So really, there's a lot of work there, and I agree with colleagues who have worries that if the data is not of poor quality or not generated within the continent, it will bias the models that are out there, or it will not give us the best yield. I agree. We need to really put a lot of investment in that. The second one is on infrastructure. And I did mention before that, and we did realize this, many of us, during the recent funding readjustments and cuts, that you cannot build systems based on licenses. It can work when you're showing the proof of concept. It can work in the short term, but in the long term, governments should host these systems. We need to support many of the colleagues on the call who do have the access to the platforms that you can do advocacy or support budgeting and support building this capacity in country. We need to host these systems. We have to build government infrastructure to host both the data and the systems. There's no way this is going to yield the potential that it has if it is not being hosted and managed in country. And then lastly, governments do have appetite for this, but I think we do also have work that is cut out for us. We have to show that value. And for example, the presentation that has just come in, you have seen some of the decision support through the consultation for PHC that has already yielded some impact. We need to interface these findings and more with the government officials. So there is appetite, but also this is a drum you have to keep beating till it's hard. And so, yeah, I think that answers the three questions. I'll be in the chat for any other questions. Thank you.
Thank you very much. I think that's a great insight as well. And there are several questions. So if you get time, if you can respond some of the questions on the chat, that would be great. So if I can come back, Mr. Tammany, to you, I think from your presentation, as you can see, there are several questions which are coming. Like to share your experience, and also as using AI at the frontline healthcare workers to empower them. I think that's really one of the big potential as everyone can envision. So from that perspective, I think there are a couple of questions which are coming. One of the questions which interests me was what about real-time data use in generative AI tools among health extension workers? And then the other one is the interoperability. Like on the health extension workers app on the tablet, is the AI a separate app or is it integrated with the ECHIS? Was one of the question. And then the other repeated question was on the privacy, when they use AI from the patient safety perspective as well as from privacy perspective, and then how we can make also frontline health workers, those health extension workers, confident in using those systems, those has been some of the repeated questions as well. And then the last one, if you can replay, is to what extent should AI allowed to influence clinical decision making, which is quite interesting as well. If you can reflect those questions, I know there is no direct answer for all those questions, but from your experience of HEPASIS, if you can just share your perspective on those important questions. Back to you.
Yeah, thank you, Professor. So, a question from I think Fan Tao is regarding to ethical considerations, privacy that he has mentioned. Yeah, this is also our concern. Yeah, that is why we gone through human in the loop, even in the implementation, UNCA implementation. But to tackle these privacy and ethical considerations, we have done some maximum efforts. One is we have developed with the Ministry of Health a strict protocol. So a protocol was developed by the Ministry of Health, especially on ethical use of this solution at the health extension workers territory. What they have to do, what they have to keep, secret even from the client, or how they should interact with the client, how a general awareness of where the data sits, how it's maintained, the identification of this personal information, everything is detailed here. So we have made this continuous workshop to develop this guideline, protocols for this. The other thing as to the privacy, especially with the data part, we store this data locally on a kind of RAG database that we have. So it means even if we do use language translators like Gemini, it doesn't mean that it sits on the cloud somewhere external, but it sits on the RAG database. All the chat histories, the responses, the query itself, all are stored there. And we feel that the personal data is not shared elsewhere. These are some things that I can mention. The other thing as to that of real-time use of data is interesting. So even if we implement RAG, so we rely on these protocols, guides, and the manuals. But there are client historical data that could also be one form of data source. So for this one, especially the data that's the client data that's collected by the ECHIS and stored on the Ministry of Health's data servers, I think there is a way that we can also include this one as a data source. So it means that the protocols, the manuals could be one source of truth, but the data can also speak. So the idea is to integrate with ECHIS data so that these real-time transactional data are also one source for the LLM itself to reference. As to the integration, I have said that, but we have also a plan to integrate with that Extension Essential, a learning app that we use. So currently it's a different app. Yeah, of course, it's a different app. HEPAS is a different app, but it is an integrator. We feel that it's an integrator. But we are also closely working with the ministry how we can access this ECHIS data. I think I have captured those two. What was the third one that you have mentioned? Sorry, I missed.
You already responded. Thank you. Thank you, Mr. Tamene. So
there are a lot, sorry, I didn't reflect on all of them, but maybe I can respond on the chat, but in the interest of time, I don't know if I have time.
Yeah, I think at the interest of time, I think it was a great presentation. And also there are great questions as well from panelists. I encourage everyone to continue the conversation. If you can reach out to Dr. Mehdi as well as to Mr. Tamene, that will be great. But my overall take is the AI is not coming, it's already here. So for our health system, I think we have to innovate, we have to test it, and also we have to make sure that we are using AI in a way it's responsible, in a way it doesn't compromise the safety of our patients. And then that needs a lot of evidence, a lot of research, and also a lot of conversations like this. I think I was quite moved by the conversation we have, a very important conversation today. Thank you for joining. And also from the chat, I just shared for those of you who has innovations, AI innovation, and then who want to test. There is an open RFP which is entitled Evidence for AI in Health. On the chat, I shared that link as well. If you have those kind of like something you're testing, you can go ahead and then you can submit. It's an open RFP by the Gates Foundation, the Wellcome Trust, and then others. They together have that kind of open call, especially for loads of settings. If you can apply there, that would be great. Once again, Mr. Tammane, Dr. Mehdi, thank you so much. I will take it back to IPHC team. Thank you, IPHC team, for bringing us together for this conversation. Back to you for the closing. I think we are on time. Thank you.
Yeah, thank you so much, Professor Binyam, for excellent moderation, and also presenters for the great presentations and sharing your perspective and experiences in the country and in your projects. I think it was great, one of our greatest sessions, and very engaging and interactive. I hope the audiences also learned from and get some insights from this platform and from this session. So we'll keep having such kind of sessions in a monthly basis. So I would like to request everyone to follow our page and announcements and promotions so that you could stay tuned on upcoming sessions as well. So thank you so much again. Have a good day, evening, and turns. Thank you so much.
Thank you, everyone.
Bye. Thank you.
Bye.
Thank you very much. Have a nice day.
Thank you. Bye.
Thank you, everyone.